speaker is from Italy, Dr. Antonio Fratini, which will speak about TECSA or not TECSA, the diagnostic dilemma.
Good evening, everyone. I'm Dr. Antonio Fratini. I'm a resident at Gemelli Hospital. In our hospital, we attend 2 to 3 months at the sleep center during our residency. So we found this case that I thought was interesting. It's about, the title is TECSA or not TECSA, the diagnostic dilemma. We managed a 67 years old male patient with OSAS and myasthenia gravis. So he was first diagnosed in 2020 with OSAS, and he was initially managed with bilevel positive airway pressure ventilation. This is due to the concurrent diagnosis of myasthenia gravis. It's pretty standard in our hospital to give this kind of prescription to the patient, also because we can manage their main illness at home more easily during the time. So we had myasthenia gravis with positive anti-mask antibodies since 2012, and he was on immunosuppressive therapy with azathioprine until 2016, discontinued because of leukopenia and thrombocytopenia. He has undergone several plasmapheresis and a history of GERD, also esophageal varices and cryptogenic chronic liver disease and herniated disc. That's the anamnesis of our patient. His initial therapy was pretty standard with the pressures. The IPAP was 14, the EPAP was 7, and he had oxygen supplementation of 1.5 because of the respiratory insufficiency because of the myasthenia gravis. No need of other adjustments for 2 years. So on October 2022, we performed a nocturnal follow-up oximetry using the VPAP ST device in S-mode, so his domiciliary ventilator. We perform every 2 years the nocturnal oximetry, and every 2 years the polygraphy. So each year the patient does a test, an exam, and a follow-up visit. So the settings were the same. The oximetry was performed with the oxygen supplementation, and the results were good with mild hypopneas, no evidence of hypoxemia, so the T90 was 0, and the ODI were 7.7 per hour. During the scheduled visit on the same day, the patient was symptomatic, though. So he had xerostomia, irritability, nocturia, and based on these findings, we adjust the device settings with the new BPAP parameters slightly increased. So we increased the EPAP to 8.5, the IPAP to 16.6. And oxygen therapy was discontinued because the patient had no respiratory insufficiency. We did a follow-up polygraphy, not a polysomnography, because in our center it's not standard to prescribe it, so it's a polygraphy, cardiorespiratory polygraphy, 1 year later. At this point, the case becomes noteworthy, also because, as I told you, I spent 2 months in the sleep center, and so this was the moment in which our team approached the patient for the first time, and I was doing the draft refutation of the polygraphy, of the cardiorespiratory polygraphy, and I was really surprised with the results, because I don't know if you can see, but The AHI index was 36.7 per hour, and the events were almost only central. I was really surprised by these results because, as I said before, the patient has been stable for years with his BPAP treatment. There was no clinically significant hypoxemia also. T90 was 4.4, also because the oxygen we were not giving oxygen to this time. So we did some investigation on the patient. The patient weight was 74. He increased 1 kilogram since the last checkup. His height is 174. The body mass index is normal, 24. Neck circumference is 41, and the Mallampati score was 3. SpO2 on room air was 97. In this period of his life, the patient was compensated with myasthenia gravis, so no respiratory sufficiency. And lung auscultation was almost normal with some mild expiratory wheezes on the left side. He drank 1 caffeinated or energy beverage per day, and occasionally he took a 30-minute afternoon nap. Doesn't work shifts, and no changes in his therapy, he referred. No major changes in his lifestyle. On the Epworth scale, he scored 10. Morning fatigue, irritability, nocturia,